Hello, this is Carol Flakler and Charmaine Cottrell talking about neurodevelopmental disorders for human behavior and social environment 2.
Neurodevelopmental disorders are described by the School Psychologists Research Forum 2012 as disorders of brain function that affect emotion, learning, and memory.
What are neurological disorders? These disorders are impaired growth and/or development in the brain's central nervous system. Some of these disorders include autism spectrum disorder, intellectual disorders, cerebral palsy, sensory-related disabilities, metabolic disorders, and degenerative disorders.
When do they manifest? Neurodevelopmental disorders generally manifest early in development, often before the child enters grade school, and are characterized by development deficits that produce impairments of personal, social, academic, or occupational functioning.
Neurodevelopmental Overview Video. This video by Matthew Jensen, published on December 22nd, 2014, shows a good overview of how neurodevelopmental disorders develop and what they are.
In this video, I want to talk a little bit more about the neurological diagnostic method, but I'm still going to stay pretty light on the details. We'll save a lot more details for later videos. Diagnosing which disorder is causing a neurological syndrome can be difficult because there are hundreds, if not thousands, of syndromes, different neurological syndromes. And recall that a syndrome is a collection of symptoms and signs from dysfunction in part of the nervous system. So let me just write syndrome 1, syndrome 2, and syndrome 3 here to represent some different syndromes. For example, like weakness on one side of the body could be syndrome 1, or abnormal language and speaking could be syndrome 2, or loss of part of the vision could be syndrome 3. And there are hundreds, if not thousands, of these possible neurological syndromes, depending on how narrowly or broadly they are defined. But then there are also hundreds, if not thousands, of neurological disorders. So actual diseases or types of pathologies that can cause dysfunction in parts of the nervous system. So let me just write disorders A, B, and C to represent some different disorders that could affect the nervous system. For example, let's say A is bleeding into the brain, and B is a metabolic problem affecting all the nerves, and C is some kind of tumor that's compressing the spinal cord. So there are lots of neurological syndromes, and there are lots of neurological disorders. But to make matters even worse, many neurological syndromes can be caused by more than one neurological disorder. So whatever syndrome 1 is over here, perhaps it could be caused by any of these 3 neurological disorders. So that just by knowing that syndrome, you still have a list of possible disorders that could be causing that one syndrome. And it turns out the opposite is also true. Many neurological disorders can actually cause multiple syndromes. So that we could say disorder A here could actually cause syndromes 1, 2, or 3. That you could get different syndromes from the same disorder. So the sheer number of possibilities trying to connect neurological syndromes to the disorder that's causing them can make this a daunting task, trying to make the diagnosis of which disorder is causing the syndrome that your patient has. So the way I approach it, and the way I think most neurologists approach this, is to break the diagnostic process down into a few steps. For me, and I would encourage for everyone, step number 1 is to locate the lesion. Where is the problem in the nervous system that's causing the neurological syndrome? And that usually just takes 2 pieces of information. What are the symptoms? And what are the signs, the abnormalities found on examination? And the first part of this step is to actually ask, is the problem in the nervous system? Because sometimes what looks like a neurological syndrome is actually a problem with another of the body's systems and not a problem of the nervous system itself. But if you think the problem is in the nervous system, the next part of this I ask is the problem in the central nervous system, the brain and the spinal cord, the central nervous system? Or is the problem in the peripheral nervous system, somewhere in all the nerves outside of the central nervous system, going out into the periphery? Or is there a problem of both? Is there dysfunction in both the central nervous system and in the peripheral nervous system? And the reason I start with this step, locating the lesion first, is that disorders tend to affect either the central nervous system or the peripheral nervous system, or both. And by figuring this out first, you often whittle down the list of possibilities from hundreds of or thousands of neurological disorders to a much smaller number that affect the parts of the nervous system that you think are involved. Now, unfortunately, there are some neurological syndromes where we're actually not sure where the problem is. Many of these we think involve a dysfunction somewhere in the brain, but some disorders we're not even sure if the problem is in the brain or another part of the nervous system. So for these syndromes, one actually has to learn some pattern recognition and can't use this kind of stepwise process to help narrow down the list of possible disorders that are involved. Step 2 for me is to further narrow the list of possible diagnoses by factoring in the syndrome time course. Time course, or some people will use the term tempo for the syndrome time course. And this is the temporal pattern or the timing of the symptoms and signs of the syndrome at onset and during the subsequent course of the syndrome after it gets started. The time course of the start, and the start we call onset, so I'll just write that, the onset of the syndrome, turns out to be particularly important. So let me put a little star next to that. So the speed of the onset often gives you a lot of information about what type of pathology, what types of disorders could be causing the syndrome that you're looking at. Because some types of pathology tend to create a syndrome that develops very rapidly, whereas others tend to develop much more slowly. There are a lot of different terms people use to try to describe the time course of a syndrome. Unfortunately, the terms aren't used consistently, so there's often some confusion when people are using the terms in a little different way. For the onset speed, some terms that are commonly used include the term acute, or sometimes people will say sudden, to mean that a syndrome is developing rapidly. Often people will use this for a syndrome that develops over seconds to hours. The next term that's used commonly is called subacute, which is slower than acute, but not the slowest. And often people will use this for a syndrome that develops over days to weeks. Lastly is the term chronic, or some people will use the term gradual. And often this term will be used for syndromes that develop over weeks to years or even decades. There are a lot of other terms that are used after a syndrome has started for the subsequent course, and I won't write them down. I'll go into detail about them later, but terms that can be used for subsequent course include continuous or episodic, if the syndrome is there all the time or if it's coming or going, fluctuating or static, for a syndrome that's not going away but is changing or is not changing at all, and resolving or progressive, for something that's getting better or something that's getting worse over time. Step number 3 for me, is now to factor in what are called risk factors. Risk factors. And risk factors are anything specific about an individual patient that puts them at risk for certain specific disorders. And patient risk factors for neurological disorders may include things like their age, their sex, if they're male or female, and many other possible pieces of information found in a number of different areas of what we call the patient's history. This could include things in their past medical history, for instance, if they've had a heart attack in the past, or what we call the social history, such as if the patient smokes cigarettes, or in the family history, if a certain disorder has run in the family and is genetic, and even things like what medications a patient takes, or if they have certain allergies. So when I go through this 3-step process, by first narrowing down the types of pathology that may be involved, by figuring out where the lesion location is in the nervous system, and then further narrowing down that list by factoring in the time course, then sometimes the patient's risk factors will really zero me in on a few specific disorders that are most likely for an individual patient. Now, when I go through these steps, I end up with a list. Usually it's a list. Usually I don't get down to just one, but I get down to a few disorders that are most likely, and then we rank them by probability. So might say that the most likely disorder causing the syndrome is disorder A, and the second most likely is disorder B, and the third most likely is disorder C, and that everything else is pretty unlikely. These would be the most likely ones. And this list of likely disorders ranked by probability is called the differential diagnosis. Differential diagnosis. It's the differential diagnosis list. And the differential diagnosis really guides everything that happens next, including the strategy for ordering tests or administering treatments, if any are necessary. And this strategy, this approach, is really the same as for every other system of the body, for disorders of any system in the body. But for neurological syndromes, this step one, this kind of locating the lesion step, tends to be much more involved because of the size and the complexity of the nervous system. Sometimes skipping steps or doing them in a different order can work out just fine for certain situations, but I find that it often increases the risk of making the wrong diagnosis, particularly skipping step one, trying to figure out where the problem is in the nervous system, or starting with the patient's risk factors. I find that those changes in particular can increase the risk of ending up with the wrong diagnosis.
What are they? Many of these larger disorders can be broken down to more commonly relatable areas. Intellectual disabilities, previously referred to as mental retardation, and severity is measured by the use of an IQ rating. Global development delay, new to the DSM-5, is specifically for children under the age of 5 who cannot complete the assessment of intellectual functioning.
What are they continued? Language disorder, speech disorders, childhood onset fluency disorder or stuttering, social and communication disorders, autism, specific learning disorder, developmental coordination disorder, Tourette's, and chronic motor or vocal tics.
Research. Key findings by the Journal of Child Psychology and Psychiatry's Annual Research Review 2015 stated, twins are confirmed to have a high heredity of neurodevelopmental disorders and less replicable gene disorders. And also that environment factors for variants and rare mutations are inconclusive for determining mechanisms causing developmental disorders.
Research continued. The key genes involved in neurobiological functions are not unique to a single developmental disorder. Things like ID, ADHD, and ASD are increasingly viewed as disorders and will continue to be broadened on the neurodevelopmental disorder spectrum of underlying loss of function and potential gain of function basis.
Research article summary. In a research article entitled A Descriptive Study on the Neonatal Morbidity Profile of Autism Spectrum Disorders, including a comparison with other neurodevelopmental disorders, by H.O. Atlader, Schendel, Parner, and Henriksen, 2015, a population of infants born in Denmark during the years of 1994 through 2010 who survived the first year of life were studied.
Research article summary continued. The study was conducted with the following goals in mind. Note the neonatal morbidities of the infants. Determine how many of the infants with morbidities were later diagnosed with autism spectrum disorder. Compare the profile of those diagnosed with ASD with the infants who were later diagnosed with attention deficit hyperactive disorder, cerebral palsy, epilepsy, and intellectual disability.
Research article summary continued. The study noted that previous studies have associated low APGAR score, premature birth, low birth weight, and placement in the neonatal intensive care unit with children later diagnosed with ASD. These were referred to as nonspecific neonatal factors in the study. The study also noted that respiratory distress syndrome, or RDS, intracranial hemorrhage, IVH, is associated with a later diagnosis of ASD. The study wanted to look at the association of these specific neonatal diagnoses along with others as a way to guide future clinical research.
Summary of research article continued. According to Aladaughter et al. 2015, children with neonatal morbidities are at risk for a variety of other neurodevelopmental and cognitive problems. These are IVH, neonatal seizures, periventricular leukomalacia, PVL, are associated with a later diagnosis of cerebral palsy, epilepsy, and ID. Bronchopulmonary dysplasia, sepsis, and necrotizing enterocolitis are associated with poor developmental outcome.
The researchers compared the neonatal morbidities of children with ASD with the neonatal morbidities of children with other neurodevelopmental disorders to discover whether there were differences between neonatal factors and the developmental disorders. The findings are children with ASD who were born before week 32 gestational age had higher rates of BPD, NEC, IVH, retinopathy of prematurity, neonatal seizures when compared to all infants in the study born before the week 32 gestational age.
BPD, NEC, IVH, ROP, and neonatal seizures were rare in infants born after 32 weeks gestational age, less than 1%. However, those children with IVH and NEC at 32 to 36 GA and neonatal seizures at 37 to 41 GA were much higher in children with ASD than in the general population. Children with ASD who were born at 32 to 36 GA or 37 to 41 GA also had more incidences of neonatal morbidities of sepsis and hypoglycemia compared with the general population.
Children with ADHD had slightly higher incidences of sepsis and hypoglycemia at 32 to 36 GA, BPD at less than 32 GA, and neonatal seizures and IVH at 37 through 41 GA compared to the general population. Children with CP, or cerebral palsy, had the highest incidences of neonatal morbidity than all the other diagnoses and were significantly different from the general population. IVH, PVL, and neonatal seizures were significantly different than the general population. Sepsis, hypoglycemia, patent ductus arteriosus, PDA, persistent pulmonary hypertension of the newborns, and NEC occurred more in those diagnosed with cerebral palsy than the general population.
Children with epilepsy had similar findings to CP, IVHA, PVL, and neonatal seizures, but were more like children with ASD in incidences of sepsis and hypoglycemia. Children with epilepsy did not have higher rates of BPD and NEC when compared with the general population. This is in contrast to those with ASD, CP, and ID. Findings surrounding children with ID show a similar pattern of CP in regard to neonatal morbidities, but are more like children with ASD in regard to the incidence of BPD.
Some of the conclusions drawn from this study are, among all the developmental disorders cited here, ASD had the highest rate of BPD, and the association with RDS with ASD was confirmed. Children with ASD had less neonatal morbidities to deal with than children with CP, epilepsy, or ID, but higher incidences of neonatal morbidities than children with ADHD.
Adeldauer et al. 2015 states, we do not know whether the neonatal morbidities we observed are causally linked to the neurodevelopmental disorders studied here or just indicators of morbidity as a result of immaturity or vulnerability. This is an important point. Their study was conducted with an eye to guide future research. The authors go on to encourage through behavioral and developmental screening for infants who have experienced neonatal morbidity.
Here are some websites that we gathered. The first one is Resource Center for Accessible Living. This website is a wonderful example of a comprehensive direct services organization. They work with many different kinds of community agencies, from schools to businesses to faith-based organizations. Some of the services they provide are advocacy, architectural barrier advisement, employment services, legal advisement, Medicaid service coordination, support groups, and transitional housing support.
Another website is CHAD, which is a nonprofit organization that supports our families with ADHD with chapters all over the country. Some of the services that CHAD provides are comprehensive information on ADHD, help locating resources, advocacy, training workshops, and support groups.
The next website we chose to highlight is the Center for Disability Rights. This organization is unique in that it is run by and for people with disabilities. It started out as a volunteer organization and has grown into a nationally recognized organization that has advocated for and won many rights for the disabled. The first legislation they won was for lifts to be installed on buses. Some of the services they provide are advocacy, TBI services, nursing home stay-at-home care, and pool trust, which is a really interesting idea. People with disabilities can put some assets into a pool trust, and then that trust will approve payment for treatment. This way they don't have to spend down their assets to get Medicaid services. I thought that was great.
Another website we chose to talk about was My Child. My Child is dedicated to providing a wealth of information, guidance, and assistance to those with cerebral palsy and their families. Some of the services that they provide are comprehensive information about cerebral palsy, what it is, causes, research, connecting to resources, information on assistive technology, managed care planning, step-by-step guide.
This last website is a research institute for autism. It's called the Husband Institute for Autism. This organization is dedicated to neuroscience research in order to improve the lives of those with autism and their families. It is attached to the University of Maryland and collaborates with other schools as well. The emphasis is on finding and implementing evidence-based approaches and to help integrate these integrate underused evidence-based therapies into the field. Some of the guiding principles of the Husband Institute are communication as centerpiece, presumption of competence, strength-based positive support, evidence-based approaches, naturalistic settings and methods, inclusion in schools and communities. The goal is to develop programs and best practices by working with families in classroom settings.
References: American Psychological Association 2013 Diagnostic and Statistical Manual of Mental Disorder, 5th edition, Washington, D.C., American Psychiatric Publishing. At Adeldor H.O., Shandell D.E., Harner E.T., and Henriksen T.B. 2005, a descriptive study on the neonatal morbidity profile of autism spectrum disorders, including a comparison with other neonatal developmental disorders, Journal of Autism and Developmental Disorders, 1 through 14.
Jensen M. 2014, December 22nd, Neurological Diagnosis Method, retrieved from www.youtube.com. Watch these CO1KOTAF JZA. Not sure I should have done that. King J. 2014, Assessment and Diagnosis of Neurodevelopmental Disorders, Deconstruction, the DSM.
Kaiser, V.P. Rivera O. and Lech K.P. 2015 Annual Research Review, The EPI Genetics of Neurodevelopmental Disorders in the Era of Whole Genome Sequencing, Unveiling the Dark Matter, Journal of Child Psychology and Psychiatry. McDonald, McCrae, Gurfey, Mounds, Robinson, Townsend, Roberts. Research formed The Importance of Differential Diagnosis in Neurodevelopmental Disorders, Implications for IDEIA, Division of School Psychology and School Psychologists.
So we've come to the end of the presentation. Thank you for watching. Hope that you gained some information from it.